Good afternoon. These are our disclosures. We know from our research and from previous papers that adolescents surgically treated for idiopathic scoliosis, either with Harrington or CD, have more pain and poor quality of life than their peers in adulthood. This raises a question: which are the factors that contribute to these worse clinical outcomes? So to address this, our study aimed to identify clinical and radiological parameters that could be linked to these long-term clinical outcomes based on current knowledge. So we designed a cross-sectional multicentric study, and patients meeting the inclusion criteria were invited to participate. Those who agree completed a set of prompts and underwent X-ray and lumbar MRIs. On X-ray, we measured the classical coronal and sagittal parameters and further calculated the gap score. In addition, an independent radiologist scored degenerative changes at L3 as one level on MRI. So we performed comparisons between groups, and we conducted a linear multiple regression analysis with prompts as dependent variables and demographic, surgery, and radiological parameters as independent variables. So 115 out of 152 included patients underwent both radiological exams. The mean follow-up period was 30 years, with an average age of 45. Notably, 90% of the patients received the CD instrumentation, and almost 50% of them were fused to L4 or below. 70 patients required almost one reoperation during follow-up, primarily implant removal, but in 5 cases, distal extension was needed. On MRI, 317 discs were evaluated, rivaling a higher prevalence of severe degenerative changes at L5 S1 level. Regarding sagittal alignment, most of the patients were coronally and sagittal balanced, with 50% of them having a proportionate spine based on their gap score. However, 80% of patients exhibited hypolordosis 30 years after surgery. Next, we divided the sample into groups based on SVI, aligned and misaligned patients, and we observed that misaligned patients has worse regional lumbar alignment and more degenerative changes at L5 S1 level. And they also scored lower in self-image and health-related quality of life. And a similar trend was observed regarding alignment and degeneration in patients with longer fusions. Moreover, the length of instrumentation seems to be related with pain, but this association could not be confirmed in the multivariate analysis. Next, we divided the sample into 2 groups based on NRAS and ODI scores, those with poor and good outcomes. And we observed that the poor outcome groups have more sagittal imbalance, and also they have a higher average number of reoperation per patient. And they also received a higher number of distal extensions, but we could not find significant differences, probably due to the small sample size. However, the multivariate analysis support these findings, indicating that the number of unplanned reoperation and sagittal imbalance are associated with all evaluated outcome measures. Of course, this study has some limitations. This is a cross-sectional study, and we do not have a control group, and there's also some issues with the with the loss of follow-up. So in conclusion, after 30 years of eye surgery with third-generation implants, mainly with CDI, the majority of patients are coronally and sagittally balanced. Although they have a decrease in lumbar lordosis, most of them are well proportionate based on their gap score. We also found that sagittal misalignment is linked with a higher degeneration rate on MRI and with poorer outcomes, and that the number of unplanned reoperations negatively impact pain, function, and health-related quality of life. So, to summarize, sagittal alignment and the number of reoperations are the main drivers of long-term clinical outcomes in our cohort. Thank you for your attention, and thank you to my co-authors.